In this video, we will demonstrate the technique of performing a Jones surgery for lower eyelid senile entropion. Lower eyelid entropion is commonly seen after the age of 60 in patients with lax lower eyelids. There is an interplay between multiple factors which can either lead to an eyelid turning in or out, which includes the laxity of the eyelid, overriding orbicularis muscle, and sometimes even in ophthalmos. There are multiple clinical tests which can help you differentiate or grade the amount of entropion, which include the distraction test, testing the lateral canthal tendon laxity. The distraction test is used to grade the amount of laxity of the lower eyelid. Depending on how fast the eyelid returns back to its position, it is graded at 0 to 4. There are multiple procedures which have been proposed for correction of lower eyelid involutional entropion, and we will be discussing about Jones procedure in this video. Surgery begins by placing the lower eyelid on a traction suture. Following this, a subciliary incision is made close to the lash line, either with a monopolar electrode or with a 15 number blade. The orbicularis comes into view, and the orbicularis is dissected away from the tarsus till the lower edge of the tarsus is seen along with the vascular arcade. The retractors of the lower eyelid lie in close relation to the conjunctiva. They are very similar to the levator muscle in the upper eyelid. Once the retractors come into view, with the forceps, they are dissected further away from the pre-aponeurotic fat pad. The lower eyelid retractors is actually a condensation of the fascia around the inferior oblique muscle. You can further ascertain the position of the retractor by asking the patient to move his eye up and down, and at the same time holding the retractors with the forceps. You will feel a small faint tug because of the movement of the retractors. Further dissection is carried out to separate the retractors from the pre-aponeurotic fat pad. Once this is done, using a 6-0vicryl suture, the retractors are then reattached to the tarsus. Care is taken to pass the suture in a partial thickness manner to avoid abrasion on the cornea. As soon as you tie the first knot, you can see the outturning of the lower eyelid. The reattachment of the retractors to the tarsus should be done in a way that you do not end up with an overcorrection. The knot should just be tight enough to cause eversion of the eyelid. In cases where there is gross laxity of the eyelid, you might need to add a lateral tightening stitch or a lateral tarsal strip to prevent frank ectropion. A strip of pretarsal orbicularis is then depulped to avoid further overriding and to weaken the orbicularis muscle. Once this is done, some people choose to excise a little bit of the excess skin. It varies from case to case. Incision is then closed by using the same 6-0 vicryl suture in either an interrupted or a continuous fashion. Jones procedure or retractor reattachment procedure is a safe, time-tested and effective way to treat lower eyelid entropion because of involutional changes. It almost leaves an imperceptible scar which is very well hidden because of the subciliary incision. This procedure can also be performed transconjunctivally. Thank you.